Good afternoon, and thanks as always for joining. I hope you're staying safe and well. Look forward to giving you this update, and as always, taking a number of questions at the end from our reporters across the state. So, as always, want to begin by updating you on our case numbers. As you've seen, just in a little over 2 weeks, we've seen a more than doubling of our average case number. Today, reporting 23,272 cases and an average of 23,503 cases. Remind you, just about 15 days ago, we were reporting a 7-day average of about 11,000 cases. And you may ask why the 23,272. Maybe that's reassuring because it's lower than the numbers of 25 or even 30,000 that we reported earlier. I'll remind you that our Tuesday numbers reflect most of the day of Sunday into Monday, and then are reported Monday evening, and then we publish them on Tuesday. So these numbers a little lower than some of the other trends, but I expect tomorrow's numbers to be significantly higher, reflecting the normal amount of reporting that we see. We've done, as the governor alerted yesterday, and I've been watching, a significant number of increased tests, nearly 300,000 tests reported yesterday, with a 14-day test positivity of 8.7%. Next slide. So our 7-day positivity is 10.1% higher than our 14-day positivity, essentially telling us that the last week has been even higher test positivity than the week before, a trend that we hope to reverse through some of our new actions. When we take a closer look at this 14-day positivity and we look at what it was just 2 weeks ago, 55% increase in that overall test positivity, another direction that we hope to turn around as soon as we can as a state. Next slide. We've been talking a lot more about hospitalizations and ICU capacity, really using these as metrics, the ICU capacity in particular as a metric to define our actions across regions in the state. And just a global perspective that we've almost 71% increase in the last 14 days for hospitalizations, our highest number ever for COVID hospitalizations at just over 10,500. And just in a day, having over 450 new patients hospitalized overall. That is not just new people hospitalized, but when you account for those who've been discharged with COVID, the sort of increased number of patients hospitalized is increasing rapidly. Similarly, for ICU capacity, we've seen a nearly 70%, 68.7% increase in ICU COVID hospitalizations over the last 14 days. Next slide. So the governor and I have talked to you a bit about the regional stay-at-home order. We have 5 regions across the state. These regions are what are known as the health officer regions. We have a number of different ways of segmenting the state for various purposes. And although I think we've fielded many questions about why these regions are, from a public health perspective, have some common features. They end up also illustrating how some of our delivery systems, our healthcare systems, work together across counties. Indeed, there's no perfect way to design regions in a state this size. So you've used something that has been used in other areas before. And as you look at this map, we see that certainly the southern part of the state, the Southern California region and the San Joaquin Valley regions are really seeing significant load in their ICUs from COVID, and therefore have a small remaining percentage of ICU beds open. As you move farther north, you see higher percentage of beds open, but even in those areas, some significant concern. And I'll remind you that 5 counties in the Bay Area have elected to go forward with the state's regional stay-at-home order framework, despite having greater than 15% ICU capacity. I think it's a recognition. I applaud this recognition that the sooner some of these changes go into effect, the hope that the impact is greater and that we can shorten the time that these orders are in place. Next slide, please. So why a regional stay-at-home order? The fact is that transmission is now so widespread across our state that most all non-essential activities create a serious risk for transmission. It's also based on our past experiences in March when we flattened the curve. I'll remind you that in March, we didn't see a significant surge in this state. Our efforts were early, decisive. We all did it together, and we were able to, frankly, keep the curve down, keep it flat. We didn't see a big bump. In the summer, though, we did see a significant bump, smaller than the one we're experiencing now, and we saw how additional restrictions were the path forward to get through that. You might also ask, well, why the focus on ICU beds? Just to paint a bit of a picture for you, an intensive care unit bed is that bed that has such specialized staff and equipment, not because we don't have the equipment and beds enough, but we're worried about that staffing component. And on general hospital wards, where we have significant burden as well, but not nearly as much in our ICU. In the ICU settings, we know that nurses and respiratory therapists and other clinical leaders are not just hour by hour making changes to a patient's care plan, but really minute by minute. The need to monitor breathing machines, patients who are intubated on ventilators, the need to make sure that patients' kidneys are functioning well, that the heart is pumping enough blood to the rest of the body. Those are decisions that happen in real time and fast-moving decisions that we can only spread and stretch our ICU professional capacity, our nurses, our physicians, our respiratory therapists, our other healthcare personnel, stretch them so far before we're not able to deliver the kind of care Californians have come to expect out of our high-quality healthcare delivery system. So for that reason, we have taken a particular focus on the ICU, that we know that ICUs are not just called to take care of patients with COVID, but also patients with heart attacks, strokes, other serious conditions where that same minute-to-minute fine-tuning is necessary to get patients through a critical period onto stability where they can go and get care in our hospital wards, our general hospital wards, and even be safely discharged home. So our focus on that ICU capacity is one that we're newly focused on. We've always been attentive to it, but the critical focus on that now is because we are certainly worried that with so many patients with COVID being admitted, a predictable number needing ICU level care, that system, that fragile but important system, may be overwhelmed. And the goal of saving lives becomes threatened when that system isn't as robust and as strong as it can be to deliver care to as many Californians as need it. Our regional stay-at-home order is also based on successes from other parts of the country and their own actions moving through restrictions and building up to more nationwide closures. Next slide, please. So we wanted to highlight a little bit of the stay-at-home orders and the experiences in Europe. Europe has often been a few months or weeks ahead of where the United States has been, even as California has itself had lower test positivity, lower impact of COVID compared to other states. Europe is a bit in front of us, and they have demonstrated some actions that we can learn from. And part of our stay-at-home order really has learned from other experiences across Europe. I'll highlight a few here. Belgium, when they imposed a nationwide closure, the positivity rate in just 3 weeks fell from 21% to 8%, showing that if we do this regional stay-at-home order effectively, we can see in short amount of time a significant reduction in our own test positivity. England, when they imposed, after weeks of going through less significant restrictions, the decision for a 4-week national closure that included non-essential businesses, limits on gatherings, very similar to what we have as our regional stay-at-home order. They saw cases drop 30% overall, and in some of the hardest hit communities, a 50% decrease. Similarly, in France and the Netherlands, when they have done nationwide closures, they've begun to see drops in their own positivity rates. So rather than focused on the sector by sector restrictions, the top of our message is, as much as you can, stay at home. We know that it works. We know that we can bring transmission rates down and move back into the blueprint for a safer economy that we've been using for the large part of the last 3 months. Next slide, please. So as a reminder of what you can do in the regional stay-at-home order, Californians are important to do things like continue visiting their physicians' offices and their providers, buy groceries, get gas, pick up prescriptions, get a flu shot. Important to do that if you haven't already done it. Visit a local retailer or worship outdoors. Members of the same household are encouraged to maintain physical and mental health by safely using our outdoors, our parks, our beaches, our hiking and walking, bike riding with members of their own household. And we are also encouraging everyone, especially as we move into the December holidays, to keep connected with loved ones virtually. I think many of us experienced this over Thanksgiving. I know I did. We had my mom on Zoom much of the day, in and out with the kids, enjoying dessert as well with us. And it worked better than expected. Wasn't perfect. We know it was quite different, but it did allow us to connect with a loved one. My mom, who usually spends the time with us, but this time around made the decision to keep her safe, to make sure we didn't create additional chance for others to be impacted by our actions, and stayed at home. Next slide, please. Also wanted to take a moment to update you and clarify certainly what we're doing about travel. Again, overall, we want Californians to stay home, and that's statewide. We know that the regional stay-at-home order restricts this significantly in those communities and counties affected by the regional stay-at-home order. But even if you're in a county or in a community that isn't under the regional stay-at-home order, we ask you to consider canceling travel plans, discouraging others to come visit you. We know that's hard. We know that these are difficult choices to make, especially 8 or 9 months into our response. But we believe that these are important decisions to make to keep our communities safe. Hotels and vacation rentals should not rent to people coming from those regions under the stay-at-home order, except for essential purposes. Travel for our critical infrastructure business sectors that require employees to travel, spend a night in a hotel to do business, hopefully return to their homes as soon as it is safe and possible for them to do so. That is an appropriate use of our hotels and lodging. And then, of course, we've talked to you quite a bit about the need to quarantine and isolate. Counties across the state are using hotels to make this a safer, more feasible option for many Californians by helping secure a hotel room for those who need to quarantine and isolate to reduce transmission for their households, for their communities, and statewide. Next slide, please. So before wrapping up, I'll end with the way we always end, to encourage you to follow these simple acts that make a big difference for COVID and the flu: to stay home as much as you can, to wear a mask, to maintain your distance, to wash your hands, to don't outside of your household, and another reminder to get your flu shot. We know that California usually experiences our surge or our peak in flu early each year in January and February. But as we approach the end of December, we'll see cases increase. And that pressure, not just on all of us to keep our households healthy, but also additional pressure on our hospital system as we see the pressure already from COVID is real, significant, impactful, and additive. So we want to do all we can. Because the flu shot is an additional tool in our toolkit, I encourage as many of you to consider getting it if you haven't already. Next slide. So it is true, we've done it before. Together, we can stop the surge. As these rates of transmission get stronger, I'm confident we will too, that our actions can make a difference. I know you're all tired. I know that it's exhausting. I certainly share some of that exhaustion as well. And I know that it's difficult to make the decisions that we're asking you to make. I know that many of us feel that this is getting, old and tiring. But with that said, I think the optimism and hope of vaccines coming around the corner, our ability to first protect the most vulnerable in our communities, those that are on the front lines of our healthcare delivery systems taking care of our sick, is a moment that we can't wait for any longer. It's coming soon. And so it makes the decisions of the day and our actions today even more important as we see the glimmers of a light at the end of the tunnel and the hope of protecting our communities, not just with these actions, but that additional tool of a vaccine in the weeks and months to come. So with that, I'll go to the first question.
Jocelyn Moran, CBS President. Jocelyn Moran, CBS President.
Hi, this is Jocelyn with C27. I was just wondering for the Central Valley, one of our big issues right now is staffing, and just seeing the San Joaquin Valley below 6% ICU availability. I was just wondering what the conversations with Fresno and other cities within the San Joaquin Valley have been as far as getting more staffing to the Central Valley. Thank you.
Yeah, we have a very tried and true system for counties to make requests through, so hospitals and systems making requests through their counties and their regions for additional supports, including staffing. We're getting a number of those requests across the state. We're fulfilling what we can, but it is getting harder. We know that staff is our main scarce resource, that our requests both across the state and the nation are hard to fulfill because of what's happening across America with COVID. We're reaching out to as many individuals through our health core program to get that help. And as soon as we have it, we try to get it to the facilities where it can benefit them the most. Central Valley is certainly that area currently with the lowest available ICU capacity. So they are a clear target for additional staffing requests. And it is sort of a work in progress, and not just daily, but over the course of many conversations in the day, we're having, communication with those hospitals, trying to meet the need, but also reinforcing that in order for us to really get through this difficult time, we need the actions of our communities and our citizens to make decisions to reduce transmission overall, so we can get through not just what might be a tough 3 weeks, but hopefully prevent 3 weeks turning into 6 or 9 weeks if transmission rates stay as high as they are.
Amy Taxon, Associated Press.
Thank you very much. We have a few first question. San Luis Obispo, Santa Barbara, and Ventura counties are asking to be separated from the regional stay-at-home grouping for all of Southern California. They say they'll continue to share resources with other counties and abide by health safety protocols. Is this something the state would consider, and why or why not? And also, you say any non-essential activity right now carries serious risk. but non-essential retail still is being allowed. Why? Doesn't that send a mixed message about what constitutes an essential activity? And the slide, one of the slides you showed in English indicated that we're not allowed there.
So I'll do my best. It was a little hard to hear the last part of your second question, but I'll try to answer it the best I can. So to the first part of your question, yes, we've heard from a number of counties questioning the region that they've been placed into. The Southern California region is a large one. Again, we leaned on something that the health officers have used in the past to work together to consider not just things in COVID response, but other responses. And indeed, not all parts of every region are experiencing the surge in the same way. But in order to ensure that we have a thoughtful collection of the resources in our hospital delivery system, making sure that if any region were to have a sudden increase in pressure on their ICUs, that we had a network and a system to move patients thoughtfully from every part of a region to those areas in the region where the resources exist. We've created the ones that we have. I've certainly been part of conversations asking questions about it. And at the moment, we don't have an intention to make a change to the regions. And as you can see, at least from the southern, the two regions that are under the regional stay-at-home order, in some ways, it really does represent the southern part, the southern half of the state. Even though it's the more populous part of the state, it still is geographically the southern part of the state. So even if we delineated different boundaries for the regions in Southern California, I believe that we would still see a significant part of the existing region under the regional stay-at-home order that we have outlined with the existing 5 regions. With regards to your question on retail, there's 2 parts to it. We know that even under the most significant closures that we in California and frankly almost any part of the nation have experienced, that the need to be able to do some essential activities to get our food, our eggs, our milk, other essential supplies to make sure that some of our daily needs are taken care of will continue. And the need to not do what we did the first time, which was really isolate the experiences to just a few retailers where we saw large numbers of people gathering indoors. We tried to create a system that allowed a variety of retailers to be open and operating so that customers, consumers, the public could go to places where we weren't seeing such sort of densely populated stores. And our hope is that that's what we'll see over what is a critical period, for retailers, but really working hard to make sure that people can get their essential retail needs taken care of over this period of the regional stay-at-home order.
Liz Cruz, ABC7.
Hi, Dr. Ghaly. I want to ask you about something the governor mentioned during his briefing yesterday about a new 2-day training program for nurses to then work in the ICU. Can you talk a little more about what this training is? Has it started yet? Where is it? Who exactly is it for? We've heard from nurses who are pretty alarmed by the proposal, saying that that's a very short amount of training for a nurse and that it could be unsafe for nurses and the public. So if you could address that, thank you.
Yeah, thanks for the opportunity. And first off, let me just say that nurses who work in the intensive care units, who have for years and decades, have a significant degree of training. It isn't something that you can learn in days. The ability to do what I was describing earlier, make those minute-to-minute fine-tuned decisions, reporting on the findings to other parts of the clinical team, takes a long time to not just learn, but to become really astute and perfect at. So the 2-day training that the state has put together is really meant to give nurses who may find themselves in a situation pitching in, helping out with critical patients, a bit of the different thinking that goes into providing care in an intensive care setting. It is not meant to create a cadre of now suddenly appointed, anointed, trained ICU nurses. It's meant to give just a little bit of the details and thinking that go into providing that high quality care. No one expects the nurses who complete just 2 days of training to be able to go in and solo be independent, support in an intensive care setting, but hopefully gives just a few lessons, maybe some refreshers, so that when nurses are pulled into other settings and situations, that they can help as much as possible. We know that this is not meant, and hopefully never relayed, that this is meant to certify anyone in a way that connotes the level of experience and knowledge that so many of the ICU nurses that I know personally have, and that I know are working hard today to take care of COVID and non-COVID patients alike.
Ron Lynn, LA Times.
Hi, Dr. Ghaly. Thanks so much for taking our questions. I have several just on issues statewide. One is on the issue of the outbreaks among cases among workers at the foster farm plants in the Central Valley. Do you have a sense for why this continues to happen and what should be done to protect workers? There have been some criticism, including from the Assistant Secretary of Health from HHS, who said on Fox News, I don't know of any data that says you need to shut down outdoor dining. Wondering if you could respond to that. And then finally, there's this new letter, or relatively new letter, about weekly testing of hospitals. Is it a recommendation or a mandate? And can you talk about the reasons for issuing it the way you did? Why you're imposing either a requirement or recommendation that staff members get tested at general acute care hospitals, and any reaction to concerns from hospital administrators that it's too burdensome to implement? Thanks so much.
Yeah, so I'll try to get through all three of them. First, so many of the different what we've called essential workplaces, transmission, especially now, is higher. We've seen it. What happens in the community is going to happen even greater in some of those higher risk settings. So I can't comment directly about the current on-the-ground activities at foster farms or any other particular factory or plant. But I can tell you that because we are experiencing widespread transmission, that all activities that were maybe lower risk a month ago today are higher risk, and that includes our essential workplaces. And that's why I think the work we've done as a state to secure PPE in abundance, to improve our testing capacity, to get guidance out to business owners and factories and other sectors so that we can put them in place are important, but they still need to be done and done well. And so any industry where that isn't happening, we are at risk of having outbreaks. We are at risk of having very large levels of high levels of transmission throughout. And that may indeed be happening again in foster farms and other places like it. And it is something that we pay close attention to, not just at CDPH, but with our Cal OSHA partners and our local public health and other health partners in those regions throughout the state. As it relates to the question about indoor dining or outdoor dining, I think one thing that I have tried to message and emphasize is that right now we're seeing such high levels of transmission that almost every activity that can be done differently and keep us at our homes, not mixing with others, is safer. Those are going to be the tools that help us get this under control. So the decision to include, among other sectors, outdoor dining and limiting that, turning to restaurants to deliver and provide takeout options instead, really has to do with the goal of trying to keep people at home, not a comment on the relative safety of outdoor dining. And we have worked hard with that industry to create safer ways for outdoor dining to happen, to keeping tables farther apart, to ensuring masking happens as much as possible, to create opportunities for air circulation to continue. All of those factors make sectors like outdoor dining lower risk. But right now, with the levels of transmission that we're seeing, we advise against anything that you can do in another way, in a lower risk way, that avoids you either leaving your home or only leaving your home in a way that doesn't expose you and cause you to mix with others.
David Baker, Bloomberg News.
Yes, doctor, I wanted to ask about vaccines and try to straighten out exactly how this is going to work between the state, the feds, and the drug companies themselves. Governor Newsom, when he's been talking in the most recent press conferences about getting the vaccines to California, it hasn't been entirely clear to me whether or not the numbers of vaccines that you're anticipating are coming directly from the drug companies themselves, if you're dealing with the drug companies directly and those companies are telling you the numbers that you're going to get, or if you're dealing with Operation Warp Speed and they're telling you what to expect. Could you clarify that for us in terms of just where your planning numbers are coming from, what kinds of assurances you're getting either from the feds or the drug companies about what we're going to receive?
Yeah, thanks for the opportunity to clarify. Frankly, it's both. We have interactions with both the leaders of Operation Warp Speed and have direct communication with Pfizer directly, but also McKesson, which is the entity in the middle that is distributing the Moderna, later the AstraZeneca, and other vaccines that emerge. And the way that it essentially works is our federal partners let us know the volume of vaccine that we should be receiving, the sort of window of time that we can expect to receive it. We then use that to advise our counties what their relative allocation from our state total will be. And then we make orders through the counties, through the state, to either Pfizer directly to get the shipment or through McKesson for the other vaccines. So it is, certainly communications between the state and our local partners, the county partners, the various facilities that will be administering the vaccine on the one hand, and then directly with manufacturer in the case of Pfizer, McKesson in all other cases, and then certainly with the CDC and Operation Warp Speed leadership around exactly how much we'll receive of each vaccine and the when.
Nico Savage, Mercury News.
Thank you. Dr. Ghaly, we've heard a lot of anecdotal information about spreading events. I'm wondering if the state has a more firm, data-driven sense of what kinds of activities are driving this surge that we're in now. Is it those gatherings? Is it college students coming home? Is it certain workplaces or employers? And how confident, given the scale of all this, are you that contact tracing is giving us an accurate sense of how the virus is spread?
Yeah, I think great questions. And I'll go to a part of an answer from an earlier question. With this level of community transmission, I think so many activities that maybe a month ago were indeed lower risk, that you could do it distanced with your mask on and have a low risk of either becoming infected or transmitting infection to someone else. With today's level of transmission, I think it's quite a different situation, that those activities a month ago, which were safe, are today just that, they aren't as low risk as they used to be. We do know that there are features of different activities, whether it's within a business sector or outside of the business sector, that cause transmission. Anything where you're spending longer durations of time with people outside of your household with your mask down, speaking in a high voice or singing, those all increase our chance of transmitting. Indoors, as I've said before, is worse than outdoors from a transmission risk perspective. Having fresh air circulating reduces those risks. So you can apply all of those conditions and features to a different activity, to a different sector, and begin to make calculations about where the risk lies. We've seen some of that bear out. It's not perfect. We work with our local health partners to determine where they're seeing transmission. As I've said previously, different regions, different counties of the state report different things. They often have the features that I just mentioned, that there are activities where masks come off, people spend time indoors, close distanced with lots of individuals, and then you see large scale transmission, even some of these concepts of a super spreader event where many people become infected in one setting. Those indeed are part of the transmission issues that we're facing, but largely it is so ubiquitous, so around our communities that many actions and activities are causing the transmission. As it relates to the contact tracing, I have been very impressed and pleased with our county partners, the ability to continue to use contact tracing, not just as a tool to identify where transmission is happening, but as a real powerful tool to communicate with individuals who have either been exposed and need to quarantine, or those who've been deemed positive by their tests and need to isolate, and protecting not just those individuals, but those around them. That the really brave frontline public health leaders throughout our state are continuing to use that as an important tool. And certainly it is a more effective tool with lower rates of transmission. But even at these higher rates, they continue to use the tried and true contact tracing approaches to help reduce transmission across our state. And I believe, given the ability to scale up the staffing through additional state supports, the ability at the local level to build up their own contact tracing workforces, that we will continue to use this as an important tool for the state.
Samantha Young, Kaiser Health News.
Hi, Dr. Ghaly. Thank you for taking the questions. I was hoping you could shed a little bit of light on testing. And, when we have these big increases in cases, coronavirus cases, there always seems to be kind of a big jump in the lines and testing and the lags of testing. And I was hoping you could just shed a little bit more light on that.
Yeah, thanks for the question. I think we are proud of how much testing that we've been able to do. And as the governor has said, we'll continue to try to increase our testing volumes even more. When we see test positivities that go above 8 and 9%, even 10% over 7 days, that's concerning. We want to be a state that gets it as low as possible, certainly below 5% statewide. So we're a ways away from that. And one of the ways to continue to chip away at that test positivity rate is by doing more testing, identifying those who are positive, and doing the work of isolating and quarantining effectively. And so we'll continue to use that approach and tool. We know that as the rest of the nation surges, some of our other testing options, the large national labs, even the suppliers for some of our own mighty California-based labs, become pressured and pressed. And so that turns into longer lines for testing, not just because more people are sick, more people want to be tested, but because sometimes it's harder to get a test. Thankfully, we're doing much better this time around, even despite greater pressures and surge on testing than we did in the summer. In part, that's because all of our testing partners have increased their capacity, but also because we have additional capacity in our state-based lab that's able to support various industries and sectors and allow us to provide additional testing throughout the state. We are also laser focused at the state level on working with harder to reach communities, whether those are rural communities or disproportionately impacted communities, even in urban areas, to increase the volume of testing, new testing sites coming from the state, different modalities, including more mobile testing and what we call pop-up sites, which aren't, everyday sites, but they come periodically to reach communities that need some testing, maybe not every day, but at least some reliable sense of testing. So all of those are our approaches to increase our ability to bring on testing. We know that we will need to do more. We continue to work to do more. And then I'll just take a moment because there was a 3-part question that I know I only answered 2 parts of it, but there was a question about testing our frontline health workers in acute care hospitals. We did make the recommendation that facilities plan and put in place opportunities for frontline staff that are volunteering and wanting to be tested on a regular basis, that be provided, that weekly testing helps us not just identify individual cases in high-risk settings like hospitals where obviously individuals are being cared for who know they have COVID, others who may be asymptomatic or being worked up for a potential COVID infection, that they are at risk of transmitting infections throughout those acute care facilities. So having weekly testing available not only helps us protect individuals, but it helps us ensure that we're able to identify early outbreaks and get them under control if and when they're discovered.
Andrew Sheeler, Sacramento Bee.
Hi, Dr. Ghaly. Thank you so much for your time today. So California state government offices have been seeing a rising number of positive COVID test results. Are employees at any state offices undergoing twice weekly testing as required under Cal OSHA's new rules for a major outbreak? And to follow up on that, will prison employees be tested twice a week?
So we are certainly the Cal OSHA guidance is something we're working with our various sector partners across the state to determine how to have those be in place. And to your question about prison employees, certainly looking at the testing cadence as we do in all industries to determine what is the right level of testing, not just to ensure that we're delivering personal individual results to individuals, but making sure that we do all we can to prevent one or two cases from becoming large-scale outbreaks, especially in congregate care facilities like prisons, frankly, in jails and in other settings as well.
Barbara Fader-Ostrov, Cal Matters.
Hello, this is Barbara. Yes, Dr. Ghaly, thank you. Can you please talk about how testing turnaround times are rising for the labs that process tests in California, including the commercial labs, the healthcare labs, and the public health labs? Looking at your dashboard, there seems like an overall increase in turnaround time, with some large labs having quite a bit of a drop from the first week of November to the last week of November, possibly because of increased test load. Can you speak to the reasons why?
Yeah, I think the nation has done a lot to ramp up testing, but in the face of a surge like the one we're seeing, where states are reporting 30, 40, even higher percent positivity rates, what that tells me is that a whole lot more people need to be tested to get this under control in those regions. And I'm sure there's delays in that testing, and that's driving towards increased test turnaround time. In California, we've done a lot on this. I think we've seen some increase in test turnaround time from really what was an average of 1.2, 1.3 days for most of our tests coming back, to now seeing that creep up above 1.7, closer to 2 days. And I'll tell you, that's an average. We still have a majority of the tests for our sickest individuals, the people who are being tested in our acute care facilities, our urgent cares. Often those test results come back much faster, but those who are asymptomatic, maybe getting tested in some of our more community-based sites, it might be even longer. The problem with long turnaround times is that the value of the information, both from an individual health perspective and from a public health planning perspective, starts to be diminished the longer the result takes to get. And that's in part why the governor, at his urging and his encouragement, we work to bring on what is a large statewide testing lab down in Valencia, California, in the Los Angeles County area, where we can do 150,000 tests a day. We're increasing our volume there every single day. It takes a while to get to that high level, but during the surge, we're looking for additional opportunities to use that lab strategically to address the needs of Californians, make sure that we can keep that turnaround time as low as possible, and ensure that the results that we do receive are valuable, that we can act on them, plan on them, and get this surge under control. I think that California certainly, because of our work, is in better shape than some other states, because we not only have depended on our national partners who have been wonderful on testing, our local labs, which can do certainly a mighty volume together, but also having some state assets to support all of that as well.
Final question, Patrick Healy, NBC4.
Thank you very much, Dr. Ghaly. If I make two questions. Number one, can you talk about the trajectory of the declining ICU capacity you see in the Southern California region? And do you anticipate at a point we will need to add a research facility in Los Angeles County? And the second question would be, recognizing your comments earlier on the thinking behind closing outdoor dining, there was a court decision in Los Angeles this morning where the judge acknowledged that reasoning, but said he needs to see specific data that shows outdoor dining is riskier than other permitted activities. Does the state have that data? Thank you.
Sure. So the trajectory is, as I said yesterday, when we look at hospitalizations today and the impact on not just our what we call the med surg, the general hospital wards, but also on the ICU, we know what the hospitals are dealing with today were cases from 2 weeks ago, maybe even 3 weeks ago. And you look at our level of transmission and the number of cases we were reporting 2 weeks ago, 3 weeks ago, we are even less than half of what we're seeing today. So when you ask about trajectory and projections, we anticipate not just the ongoing slope of increase that we've seen now. We are worried about a rapidly accelerating increase and pressure on our hospitals. If we thought we were sort of peaking at this level, some of the regional stay-at-home orders may not have been necessary. But the concern that with the Thanksgiving cases beginning to show in our daily numbers, that there's a number of other actions and activities at the end of the month of November that may contribute to broader spread, that we know that as you get community-wide transmission and that the virus is just more abundant and around us, that the likelihood of continuing to see high case numbers without some major change in our overall behavior and our movement, we will see hospitals continue to feel that pressure and get overwhelmed. When you do see, when you ask about a surge facility, I'll remind you that because of the hard work that we did as a state, our hospital partners, and I commend so many of them for stepping up and creating the space, acquiring the equipment and the supplies to be able to manage those spaces, that exists. So the need for a separate facility is not as apparent today as it was when we started. But the need for the staff to run those beds wherever they are is something we do need. We're working hard to find as many staff as we can, to recruit them from not just across the state, but when we can, depend on our federal partners to help us staff up. But that's a very different need than the need for additional beds. Certain regions, we talked about in Imperial County, we talked about here in Sacramento, the need for some additional beds to support Northern California. Those are being moved from what we talk about warm status to activated status in order to support some of those locations that have very few beds available for the number of anticipated individuals who would need them. But by and large, we're depending on our partnerships with existing hospitals, their hospital buildings, and their campuses to continue to care for Californians who need that level of care. As in regards to your question about outdoor dining and restaurants in general, I think our position again is to consider that the stay-at-home order really does guide us to reduce our mixing, to reduce our movement as much as we can. And that this is the time that if you want to enjoy a meal from a restaurant or need a restaurant to provide your food and sustenance, that we still have the option of takeout, the option of having food delivered, but now is not the time to spend additional time outside of your household, potentially mixing with others, transmitting the illness far and wide. So as much as possible, the guidance is avoid that, have those sectors closed in the regions that are under the regional stay-at-home order, that we do this for a short period of time, and that we look forward to moving beyond the surge, having that industry and many other sectors reopen for business and really begin to move beyond the period that we are in now. So with that, I know that was a lot of questions and mouthfuls of answers, and I apologize for that, but really always appreciate the time with each of you, our reporters, for asking thoughtful questions that help us not just illuminate the thinking behind some of the decisions, but also an opportunity to clarify some of it. I'll end by just thanking each of you, as I have before, for your incredible work. I know it's hard. I know many of you are tired of this, saying, you know, I'm not gonna change my behavior. I'm not gonna do things differently than I have been. But really asking you to reconsider that, not just for yourselves, not just for your families, but for your communities, for those frontline hospital workers, those nurses, doctors, respiratory therapists, paramedics, so many others who are picking up in order to keep our communities safe, that they need our support, they need our help. And one of the best ways to do that is by changing your own personal decisions and behaviors for this period of time, helping us get transmission down, and hopefully getting through this month that will be hard, that will be different, and into early next year, when we not just have vaccine, but we have lower rates of transmission, and we can return to a number of other activities that we all miss now. And with that, I'll end and wish you a good rest of your afternoon.